Okay then. Good morning, everyone. My name's Richard Pitt. I'm a CAPE member, and we're hosting this second Interprofessional.Global Cafe for 2022. And we're delighted that we have Professor André Veit from the University of Ghent and the European Interprofessional Practice and Education Network. And he will be presenting on the IPECP 5 key competencies. And we have Professor Amita Ray from the DMYNAT, hopefully I've pronounced it correctly, Institute of Medical Science in Southern India. And she will be our second presentation. If you could all remain muted whilst we have the presentations, as these will be recorded, and then I will stop the recording after the presentation for the 20 minutes discussion so people can freely engage with the presenter and present questions. If you have a question, you could put it in the chat box, and then I will be moderating those and put them to the presenters. This is going to be an excellent session, and I would now like to hand over to André for the first presentation.
Okay, thank you for inviting me. I'm indeed chair of the European network, and I'm also teaching at 2 higher education institutions, which are University of Ghent and Artevelde University of Applied Sciences, also in Ghent in Belgium. So my presentation is about the IPECP 5 key competences framework for interprofessional collaborative practice. As one of the elements helping to put things into place for interprofessional practice, as I would state. First, let's take a closer look on what we need for interprofessional collaborative practice. I like to distinguish 5 key pillars, which are frameworks, methods, tools, mechanisms, and policies. Now, for the latter 2, for policies and mechanisms, it was already indicated by the framework for action defined by the World Health Organization in 2010, that indeed we need more than just educate or train students in interprofessional practice. We need to involve more actors like health insurance bodies, health organizations, professional bodies, governmental agencies, and so on. So we need, for example, financial remuneration and health insurance mechanisms that support interprofessional diagnostics and consultancy. We need leadership and team coaching. We need a collective code of ethics. We need internal quality assurance focusing on collaboration, and external quality assurance and inspection bodies. But also we need common frameworks for interprofessional clinical reasoning. And one of the frameworks that has been used for quite some years now, focused on patient health domains and factors on the left top, is the World Health Organization ICF, which I'm sure you all know. But I like to focus on the right side, and these are the frameworks that we need for the health workers, and also for education and training and research and innovation. And well, I've developed a shared care matrix plan. I've also developed a tool. So both are methods and tools that can be used. But here in this presentation, we focus on a specific framework, especially for healthcare workers. And we define this as the IPECP 5 key competences. We distinguish 5 competences focused on planning and managing, referring and transferring, consulting and collaborating, and then 2 additional competences, reflecting and evaluating and handling issues and opportunities. The basic principles of this model are threefold. We use a team-based approach, we use a person-oriented care approach. You all know this, but we also focus on a problem-solving approach in which clients are active partners in trying to solve, together with healthcare professionals, trying to solve the problem of health. The core characteristics of the model is, well, when we started to develop the model, we said we want a model that is concise, clear, and easy to use. There are quite some frameworks available, but a lot of those frameworks are quite complex, and we wanted to develop a model that is easy to use so that the threshold to use it for practical purposes is very low. We focus therefore on key areas which are really essential for practice. We wanted to develop a model with competences which is educationally sound. That means, for example, that competences in this model always are a bundling of knowledge, skills, and attitudes. We wanted to formulate it in such a way that it is adapted to different contexts and settings. And we also wanted to include quality assurance aspects and, for example, also self-assessment, because there are models, existing models that focus on key aspects of clinical practice, but we said in order to have a sustainable interprofessional collaborative practice, you also need to include aspects of quality assurance and self-assessment. So we wanted to develop a model that is practical in use for assessment, benchmarking, and growth, and not only for education and training, but also for continuous professional development of healthcare workers. On the right, you see here the description of the key competence areas. So instead of trying to define a competence in one sentence, we opted for a brief nominator of the competence and a more elaborated description of the area in which the competence is relevant. So it is about consulting and collaborating, planning and managing. And planning and managing, for example, is not only in planning a shared care plan for a specific patient, but for example, also is involved in planning preventive actions or scientific projects of interprofessional characteristics and so on. So we opted for a broad description so that the key competences are adaptable or are adapted to different contexts of health and social care. On top, you have the three key competence areas which are relevant for the clinical context and prevention, health promotion, and so on, which are core competences that are to be found also in most interprofessional competence models. But on the bottom, you see two competence areas which are really focused on quality issues, reflecting and evaluating and handling issues and opportunities. So these are important not only for quality assurance, but also for improving the quality of healthcare. We assess the competences on a 5-point scale, in which 1 and 2 mean that the competence is not really acquired or only partially acquired. And so you have, let's say, a differentiation from 3 to 5, indicating the amount of acquisition of that competence. So to a minimal degree, largely present or acquired, or fully acquired and present. Here you have a view on the assessment sheets that we've developed, and you see that for the first two competence areas, there are 8 behavioral indicators. For the third, there are 6 behavioral indicators. And for the last two, focusing on quality issues, there are 4 behavioral indicators in each of the two. A closer look on some examples. Here are the 8 behavioral indicators for the area of consulting and collaborating. And the arrow indicates an item that was indicated in a first study with healthcare workers as a problematic behavioral indicator, in the sense that most of the healthcare professionals, at least in Flanders, where we did the study, indicated that they don't have adequate tools and techniques to use for interprofessional practice. So there is a clear need to develop and embed those tools in practice. The second example is about planning and managing. And again, you see at the bottom, item 16, selecting and using adequate tools and techniques to support and facilitate interprofessional planning of healthcare activities and service provision in the broadest sense. Again, healthcare workers indicated that they don't have adequate tools at their disposition. Also, they have a lot of difficulties in formulating, together with client and with other professionals, interprofessional goals for health and well-being of persons. So most persons are quite skilled in formulating goals within their own professional field, but in a broader sense, formulating interprofessional goals, that's something they have more difficulty with. Here you have an example of a self-assessment done in a sample of about 150 master students enrolled in a specific course unit for interprofessional practice. And here you see that, so this is done at the start of the course. And for example, at the top, you see that about half of the students state that they are not competent, they do not feel competent in reflecting and evaluating about interprofessional practice. So in this course unit, we learn them how to use scales, how to use tools, how to use methods for interprofessional collaboration. Here you see a self-assessment done in a sample of about 100 healthcare professionals. It is displayed in such a way that you see the difference between healthcare workers working in a monoprofessional private practice or a private practice plus center-based practice, or healthcare workers working specifically in center-based teamwork contexts. And here you see that, well, the healthcare workers have most difficulty with the 2 competence areas that are on the domain of quality assurance, reflecting and evaluating and handling issues and opportunities. You see also that there is still work to do, that there is a margin of growth in these competence areas, in all 5 competence areas. We asked on these healthcare professionals not to indicate if they are capable of interprofessionally planning and managing and so on, but we asked if they are doing it in practice. So that's also the reason why the scores are rather low, because we said if you have developed this competence during training, but if you don't apply it in practice, then we have a problem, of course. Here you see the difference between healthcare workers that were only recently graduated, or between 2 and 5 years, or that have more than 5 years of experience. And interestingly, you see that the healthcare workers having more than 5 years of experience indicated that they feel less, not less confident, but they perform less reflecting and evaluating on interprofessional issues. Now, maybe this is because in the past years, we have developed course units focusing on this aspect. And so maybe in the future, the young healthcare workers will have more competences in this sense. So we foresee for the next coming 2 years a European rollout, implying a further standardization and norm setting, but also exploring the current status of competences in healthcare workers, not only in Belgium, but hopefully in different countries within Europe. We want to test the scales also for continuous professional development, and we hope to embark European professional associations for this. We hope that it will be embedded in accreditation frameworks, not only for higher education, but also in competence charts for healthcare professions. And also for this, we are embarking European health associations of health care professions. And of course, we would also like to see that this framework will be integrated in quality assurance and accreditation frameworks for healthcare organizations. We know that there is a traditional gap between training and practice, and we need wider changes in the context and in organization. Competences or developing a competence framework is good, but we need more structures in order to support the application of those competences. So we not only need health and social care practice and education and training, but also continuous professional development and quality assurance and improvement. Helping to transform and improve health and social care by making it more effective and efficient. This is one of the core goals of this IPEN 5 Key Competences framework. You can download it from the IPEN website in different languages. We already have also a Finnish version, but so it is available in 6 languages now. You can download a nice brochure with the description of the characteristics, the behavioral indicators, and the separate assessment sheets in different languages. It is also possible to use IPECs, and this is forthcoming. So I will not elaborate on this. I will skip some slides that were foreseen to have a description on this, but it's also just simply to state that the competences framework of the 5 keys competences framework will be integrated in the IPECS practice scales within that tool that will be available within the coming 2 months normally. And then it will be possible to automatically derive indicators, let's say indexes that can be used for benchmarking. And we will specifically discriminate between indexes which point out the effectiveness and on the other hand, an index that will point out the performance. I will not elaborate on this in detail because it would take too much time. So healthcare is complex and fragile. Interprofessional collaboration can make it stronger and let it shine. And so let's focus on key competences and ensure their application in education and in practice. If you are based in Europe, you're always welcome to join IPEN. Thank you. I believe I had about 15 minutes presentation.
Yeah, you've got plenty of time now for questions. Thank you very much for a very informative, clear and concise presentation. And I applaud you on all the work you've done, especially having it in 6 languages. Was that presenting any challenges in converting it in languages, losing context or anything, Andre?
Well, not particularly. I would say if we would have done it 20 years ago, then it would take a lot of time. But now, when you already have an established network in different countries, I wouldn't say it's easy. It took some time because we used also extra checks and translated again in the English language to see if everything is okay. And mostly it was also teamwork. So not one person who did the translation, but 2 or 3 persons helping each other. And so we're quite confident that the translated versions are very useful. Yes, indeed. And so the finished version is not yet online. We've just received the finished version, and we will now back translate it again to see everything, if everything is correct. And it will be available then online within a few weeks.
Excellent. Excellent example of collaboration as well amongst the workers on the team. I'm now going to stop recording. Okay. Let's get back to it. Carry on.
So I think, could I have the previous slide, please?
Previous one. Yes.
Yes. That's the next one. Okay. The previous one, please.
Previous.
Before this.
Okay.
Okay. That's it. Thank you. Presentation. I would like to say that this study would not have been possible and without moderators who worked tirelessly for achieving this project. Our professor in physiotherapy, Narasimhan, Assistant Professor Dr. Sujoy Ray, who helped us design the question, who did all the statistical analysis for this study. Next, please. Can I have the next slide, please?
Is that the one you want, Tamita?
Yeah. Yes. 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 So, okay. I think it came to the subsequent one. When, okay. So anyway, I'll organize my talk into 4 sections, and that would be a few words about why we did this study, and next going on to the methods that we used, what were the results that came out of the study, and what did we conclude from these results, and whether these results serve the purpose of the study. So let me give you a little background for this study. India, when it became independent in 1947, the life expectancy was just 41 years. But now, as per the calculations of two. This indicates that there is a lot of there is aging population, and because of this aging population, there is an increasing prevalence. Both of these combined are putting an increasing workload on the healthcare system as well as the healthcare workers. And also, it is increasing the factors that threaten patient safety. And to compound matters still further and make them worse is the decrease in trust between the caregivers and the care. So there have been increasing incidents of mistrust litigations towards doctors in almost all the major cities throughout India. And because of all this, practicing healthcare in India is becoming. Next, please. Next, please. Thank you. Thank you. Evidence from the other evidence has shown that whenever there is increasing collaboration always helps. It is not only true for the medical or the healthcare system, it is true for any system or any profession, I gather. So collaboration, when we come to the medical or the healthcare system, it could very well be done by an interprofessional care team. And for an interprofessional care team to function, this care team would need interprofessional education. Next, please. Okay. Having said that, if anybody were to introduce a new form of education or an educational endeavor, they should make certain that there is, first of all, awareness about it. Then there should be an acceptability and a positive attitude towards this. And all these three things are very context specific. What I mean, interprofessional education has worked well in a particular situation does not necessarily mean that it would work well in another context. Next, please. Okay. So having looked at this background, we went with this aim for our study as to answer the question that if we were to introduce IPE in the Indian healthcare curriculum, would it be acceptable? Would the students have a positive attitude towards it? So what we looked at basically in this study was, is there a change in attitude after an IPE experience? And in that process, we would help in creating awareness about this particular educational methodology and also understand whether in our context it would be acceptable to the students in particular. Next, please. Okay. So ours was a cross-sectional study with a mixed methods approach. And as I told you, it was done in a medical college in tribal South India. Why I emphasize the word tribal is that in India, the medical colleges receive grants, government aid and support in place where there is underprivileged population. And this was such a college, and that is why I would like to emphasize that. Next, please. Okay. Being a Cochrane enthusiast, I have gotten into the habit to put a PICO format to my research question. And that is what we all try to do here. And if you see the P of it, the population of it rather, it was the undergraduates of 3 professional courses: medicine, nursing, and physiotherapy. The I was the intervention, and an intervention in the form of an IPE experience in postnatal care. The outcome, that change in attitude of the students after this experience. And next one, please. So we had a total of 96, and each of these groups had 2 medical undergraduates, 2 nursing undergraduates, and 2, can I have the next one, please? Okay. The intervention was an experience in postnatal care. Can I have the next one, please? Okay. Now you might be wondering, why postnatal care? Actually, and truly speaking, there were a lot of reasons why we chose postnatal care, but the chief among them were these 2. The first one was that knowledge and skills acquired during this IPE experience would be relevant to the individual curricula, and it would be more acceptable to the students, because after all, these undergraduates, the second reason why we did this IPE experience in postnatal care was that postnatal care gives many opportunities for collaboration and implementation of IPE principles. Can I have the next one, please? Now, as we know that the curriculum should be aligned very well in terms of the learning goals and objectives, the teaching learning activities, and the feedback and assessment. So that is exactly what we did with the curriculum when we designed it before administering it. So the content was to be postnatal care in terms of all the 3 domains of postnatal care, be it knowledge, be it skills, or be it the attitude. The teaching learning was done in a way as to fulfill this goal and objectives, and the assessment too was aligned with the teaching learning methodology, as well as to fulfill, or rather to see whether these goals or objectives of postnatal care have been achieved. Next, please. Okay. So the teaching learning methodology that we used, so basically, first of all, we took 2 didactic sessions which were devoted to explain the concepts and the advantages of interprofessional healthcare teams. This was by way of creating awareness, and we took some examples from other countries and one example from our own country to show that yes, when healthcare teams work together, the results or the outcomes are better. Next, please. Next was the teaching learning methodology for the curriculum in particular. So in the didactic sessions, the physiological changes, the complications, and the management during the immediate postnatal period and puerperium for the students to be learned were explained with the help of mannequins. And we took to ensure that during both of these sessions, the roles and responsibilities of various professions were properly highlighted. Next, please. After the didactic sessions, we had small group learning. So what we did was prepare some cases which were distributed among the groups that formed, and these groups discussed the cases and answered the questions in terms of what the treatment or the care objectives of this particular case, how would each profession address these objectives, draw a care plan for this particular case. Is this care, in this care plan, what is the role of each profession? And where professions help? So maybe that particular profession is not in your group, but you could identify in this case scenario. Next, please. Then we gave our students some hands-on experience. We send them to the post, and the postnatal mothers, the cases were allotted to the groups for day-to-day management, whether it was a case of a normal vaginal delivery or an So I think I missed that part. The connection was playing up. So we allotted cases to these groups, and they did the day-by-day management of the case, of course, under supervision of the clinician in charge. And at the end, they prepared a discharge summary collectively for these postnatal mothers. Next slide, please. As we know that without assessment, no curriculum is complete. Assessment is the tail that wags the dog. We did include assessment in this curriculum because we knew that otherwise the students would not take it quite seriously. Next, please. So what did we do by way of assessment? So the assessment was in the form of a poster presentation of 2 cases for each of the groups. And assessment points were allotted based on formulation of a holistic care plan for the specific postnatal scenario, defining profession-specific roles and responsibilities, and identify areas for collaboration from other professionals. So these were the 3 domains under which we collectively assessed each of the posters, and each of the groups gave 2 poster presentations. Next slide, please. Okay. Now on to the methods of data collection. So we used a 36-item validated questionnaire, and this was developed by IPE faculty at the University of Houston. The permission was obtained from the authors by email, and this questionnaire was given to all the 96 students to answer after an informed consent was taken from them. Next slide, please. Now, this questionnaire was a retro-pre approach because in order to minimize the response shift bias, most of the questions were on a Likert scale, and there were certain open-ended questions in the end also, which the students needed to answer. Next, please. The analysis was done using a paired sample t-test for the pre and post-test course, and ANOVA was used to compare the magnitude of change from pre to post. And a qualitative analysis was done for the open-ended question. Next, please. So on to the results. Here I'll take a little bit of your time. So as I told you that the questionnaire was a 36-item questionnaire, but the heart of the questionnaire were these questions. How comfortable are you with questioning a member of another profession? How comfortable are you with answering the question of another profession? How reliable do you think another profession is? Now, you'll agree with me that the best form of communication, which can subsequently lead to collaboration, is a question answer. So this was the heart of our methodology, where we wanted to know whether these three professional undergraduates were comfortable with questioning another professional undergraduates, and were they themselves comfortable with being questioned by them? And how much would they rely on the information given by each other? And this was all done on a Likert scale, and a pre-post test assessment was done. Next, please. So what we saw was a significant improvement in the attitude of all the three undergraduates professionals. And if when we saw the magnitude of change from the pre to the post, the physiotherapist showed greater magnitude of change in the questioning attitude, and the nurses showed a greater extent of the reliability, a greater increase in the extent of the reliability attitude. Next, please. Now, for the open-ended question, we did a very simple qualitative analysis in the form of a word cloud. We just put the transcripts and just saw which are the words that are coming out very prominently. And as you can see, that communication, collaboration, teamwork, these were the things that came out from the transcripts of all the 96 participants. Next, please. So to put it precisely here, according to them, the reason why their attitudes changed was mainly teamwork, communication, collaboration, and cooperation, which I think are the salient ideas behind an interprofessional practice. Next, please. To conclude, we found a positive attitude among students towards the given intervention, a significant improvement in their comfort levels with and reliability on other professionals. Both of these we felt would lead to a good acceptability for IPE in our context. Next, please. Thank you very much, and dhanyavad in Hindi.